So, Vijay Krishna sir, shall we start?
Yes, can start. Samuel sir?
Yes, Samuel sir?
Yes, sir.
Can we start?
Yes, we can start. Sir.
Can we go on, sir?
Yes.
Yeah. Right. A warm welcome to everyone to today's webinar organized by Karnataka State Physiotherapy Federation. I welcome you all on behalf of Karnataka State Physiotherapy Federation to the webinar conducted by JSS, a comprehensive approach to movement and gait analysis, which would be done by Dr. Vijay Samuel Raj. Today we have with us Dr. Vijay Krishna, who is Principal and Professor in Physiotherapy for Dr.B.R.Ambedkar College. I welcome you, sir. Thanks for sparing your time. So you need to unmute your.
Thank you, Dr.Sai, Mahendra.
Thank you, sir. And our speaker, Dr. Vijay Samuel Raj, who is a professor with JSS College of Physiotherapy. He is a coordinator for Department of Physiotherapy with JSS Hospital, Mysore. I welcome you too, sir.
Thank you, sir. Thank you for giving me this platform, and really grateful to all the team members, especially the Karnataka State Physiotherapy Federation. Also, I am just thankful and grateful to the President, Dr. Ayyappan. Yourself, you have been taking a lot of initiatives and you have been doing a great job, sir. So, Dr.Sai, Mahendra, I'm grateful to you, and as well as Dr. Vinod, principal of Gautam. So, and apart from this, all the members. So it's all the committee members and advisory board members. I'm really thankful to all of them. Yeah, all the best, sir.
Right. Thank you so much, sir. So, Dr. Vijay Krishna, sir, you would be the moderator for the session. Thank you so much. And biomechanics is something that I personally love as a subject, and I'm really looking forward to a very good session from Vijay Samuel, sir. Thank you, sir. Over to you, Vijay Krishna, sir. Thank you.
Thank you, Dr. Sai, Mahendra. It's been a pleasure to introduce Dr. Vijay Samuel, sir, Assistant Professor from JSS College. I've been knowing for a couple of years actually as a clinician and the academicians. And I appreciate and thank JSS to create a great platform to learning for physios, and particularly in this COVID-19 scenario. And of course, the topic today is like regarding Gait. I've been teaching so long time for Gait and all this, particularly for the past 20-15 years. How important Gait is, it's everything. It starts from top to bottom. We have been in a crisis to evaluate in Gait. So I think today will be a great session by Dr. Samuel sir. He will be giving a brief account about the Gait analysis and this thing. So I think all the participants who have been there will have a great session today. Yes. Over to you, sir. To Samuel sir.
Just an interruption, sir. Just to inform that we are full house, and we have a lot of viewers on Facebook as well right now. And
appreciate it.
Thank you.
Over to you, Dr. Samuel sir.
Yeah. Okay. Yeah. Thanks a lot, sir.
Yes.
So as we know the topic, right? And thank you, Vijay Krishnan sir, for the introduction. And you have been also an inspiration since every time I meet you and I talk to you during exams and other during conversation, you have been really an encouragement person to me. And thank you. Thanks a lot. And also, I'm happy that you're coordinating the session. So my topic here for today's session.
There's some issue with the voice?
Yes, sir. Am I audible?
Yes, sir.
Gait analysis. So I selected this part as one of the important thing where a physiotherapist involves in day-to-day activities whenever he sees a patient. So especially when he meets a patient or his client, it's very important that he has to assess the movement, and one integral part is again the gait. So it's very important how efficient are we in analyzing the movement as well as the gait, because that's how you set up the goals, you develop an hypothesis, do a clinical reasoning, and you give appropriate treatment so that the patient can get better. Okay, so today's session I'll be doing with a brief description of the movement analysis. I'll be just talking about what is movement analysis and related components like kinetics and kinematics and biomechanics, how they are important in movement analysis, and also where the need for analysis lies, especially in sports, clinical research and in patient care. And I'll be talking with little methods. What are the different methods? Just an insight. I'll not go in detail. And I'll be introducing a software called Kinovea, through which you'll be able to evaluate efficiently. And I'll be talking about the features, key features of the software and its application. And by this, we'll have a conclusion and maybe a discussion session. Right, coming to the basics of motion analysis. Movement analysis is nothing but it is facilitated by acquisition of objective data that describes a subject's movement and a physical examination and relevant functional history. So when I'm talking about movement analysis, movement refers to motion. As physiotherapists, we are specialists in movement science. We are specialists in movement, right? So more important thing is we must be efficient in analyzing the movement of all the patients. Okay, it may be pertaining to orthopedics, neuro, or any case, any specialty, we do a movement analysis, which plays a very integral part of your in the clinical approach. Okay, so in this case, the very important factor to consider is the basics. When I'm talking about movement analysis, most of the time, what we do is, even in my clinical experience of 21 years, most of the time, what we do is we do a screening. Whenever a patient comes, we just analyze. We tell them, for example. So when I'm talking about the movement analysis, the very important component, what we do in our experience, I stopped there. In our experience, in my experience personally, on 20 years, so what we used to do is, I used to just screen a patient. Whenever a patient walks in, I just screen a patient, or I tell him to move and observe what is the problem, right? Many times it is not recorded. We don't record it. We don't take it as an objective measurement, or where we usually have an outcome measure. So when it came to research, when I want to give a data to the patient, or when I want to give an improvement list to the patient, we don't know how much he's improved. Let it be with the movement or with reference to his function, we don't know how much is improved, because when we analyze by just visual without any measurement, it becomes null. That's where we are lagging here now in research. We don't have much papers coming in because we don't have the data. So when you say a patient walking in has got a specific measurement, and after the treatment, this is the measurement. If you have this outcome measures, you'll be able to easily predict and give a prognosis how much amount of improvement is seen in the patient. So it plays a very important role. Movement analysis is not just pertaining to your screening, it also has to have an objective data. It has to be measured. So when I'll not take much with this introduction, so I just want to go into practical much how to analyze. So just basics, just to touch on the basics, you need to have biomechanics as your basic, because that is the foundation. So you need to have the mechanics into line, okay, where it is nothing but the study of movements, how the things move. You're going to into detailed study where you have components like kinetics and kinematics. As you know, kinematics is nothing but the study of motion without regard to the forces. So you'll be doing only with reference to four things, that is your type of motion. For example, if you take a shoulder joint, if you're doing an abduction, what type of motion is occurring, okay? Whether it's a rotatory motion or whether it's a gliding or translatory motion, For example, if you do an abduction, you have the concave and convex rule. There is a rotation, along with there is an inferior glide during your abduction. Okay, so I'm studying in depth of this type of motion, and along with that, what we do is not only that, we also talk about the direction, in which direction it is moving. It's moving in up. So normally it is terminology, we term it as abduction, adduction, flexion, extension. Physiotherapist going into a movement analysis must be thorough with these terminologies. You must be clear with what type of movement it is, in which direction it is moving, and along with it, where is this movement located? For example, the movement is located, abduction and adduction is located in the sagittal plane, right? Frontal plane and sagittal axis. Sorry for that. It's frontal plane, sagittal axis. If you talk about flexion and extension, it is in sagittal plane and mediolateral axis or frontal axis. So you must be very clear in which plane are you evaluating, are you analyzing. For example, if you're evaluating abduction, if you stand in the lateral view and examine or analyze this movement, then you'll not be able to get the exact view or the record. So all of you know this. I'm just going into brushing up with the basics. And along with that, the third one, the fourth one is the quantity of motion has to be measured. Okay, so first is the type of motion, the location, then your quantity of motion, that is how much amount of movement is occurring in the joint. If I'm moving my wrist in this direction, I must say that is moving around 90 degrees or 80 degrees. When you visually you see, you'll not be able to measure. It's approximate, but you will not be able to tell exactly. So it's very important that you have to measure, you have to have an outcome measure during your measurement of quantity of motion or magnitude of motion. So these four components comprises with reference to kinematics. So I'll be dealing with more of kinematics today with reference to your movement analysis as well as with reference to the gait analysis. When I'm talking about kinetics, it is the description of motion with regard to the forces producing that particular motion. Okay, that means your muscles or maybe your external forces, gravity, anything which produces forces in your body, we refer as with reference to kinetics. Okay, so kinetics analysis requires much more sophisticated equipments. Okay, I'll be just talking about that. Okay, so with regard to the basics here, okay, I'll just move on to the movement analysis. I already described this. It consists of assessment of quality of movement. I want to emphasize this. You're assessing the quality of movement as it relates to functional motion with the intent of enhancing the function and efficiency within a defined space. Okay, so it's very important when you analyze, you're just not visualizing, you're analyzing the quality as well as the quantity of motion. Okay, and it's always quantified with reference to the body segments. It may be either two-dimensional or it may be with reference to three-dimensional. Okay, so three-dimensional gives you a better space for analysis, because whenever you see some joints, it's always multi-directional. So you need to evaluate with three-dimensional. It gives you a better space to have a data. Okay, so these are with reference to part. I've already described this with reference to biomechanics, kinematics, kinetics, and some few basic computer skills is necessary. Okay, so these are some of the movement principles. So you must be having a balance, coordination, force with reference to time, that is the speed. Okay, optimal projection, segmental interaction, range of motion, and inertia are few components where your movement principle lies on. So I'll just not go in depth. I'm just sticking on to the analysis. Okay, and when I'm talking about need, why do we need this movement analysis? Is it really necessary? Do we need to analyze? Okay, so when you talk about this question, when I ask this question, the important part which you refer here is analyzing a movement can help us in planning a better plan of care, right? And not only that, especially in sports, it is very essential that you need to have an analysis and which can help you to prevent injuries, plan a treatment, and also enhance the performance. It's very essential skill of analysis. We use sophisticated equipments, motion analyzer, and all those things to evaluate a sports person, and by which you are able to improve his performance. And when it comes to your clinical practice on day-to-day life, it may be in your private clinic or in the hospital where you're working in. So it's very essential that you involve this in your patient care, assessment, planning, and prognosis. And most important is the clinical research. So if you want to have a valid tool, or if you want to have the validity, and if you want to talk about a specific treatment efficacy, it's very important that you need to have an outcome measure saying that yes, this has improved. So it plays an important role as an outcome tool, data collection, interpretation, validation, and planning. So how did this evolve? Okay, when you see this human motion, you can see this, the record, like when I was just reading through an article, it was seen even in ancient Greeks. They had started with analyzing the motion. Even when I'm talking about Kung Fu and all in the early years, they even started analyzing this motion. And it's recorded with Hippocrates and Hippocrates, and as well as with reference to where he analyzed the motion. And Leonardo da Vinci, he did drawings of different motions which helped in analyzing the movement. Okay, these are some just a quick view of your evaluation. Okay, and when I'm coming to the methods, right? I'll just have a glimpse of what are the different methods we use in analyzing the motion. So we have simple things like ink mat, which we use it, where you have the shoe which has been marked with the ink, and patient walks in, where it helps to measure the stride length or step length, by which you will be able to analyze the gait. Okay, and there are photography methods through which you can analyze. And normally what we do, like right now what we do is we use a goniometer, digital goniometer, and as well as nowadays we have in phone, we have apps which we use it, which are generally we use that through phone apps, that also we do it, and also the inclinometer. And normally what we follow is we do an observational movement and gait analysis, and sophisticated equipments like motion analyzing system, automated motion tracking systems, and you have fluoroscopy, you have 2D, 3D, and X-rays, and even MRI. All these things are where through which your motion can be analyzed. I'm not going to talk about this in detail. I'll be just picking up few things with what we use in our day-to-day life with reference to patient care, and I'll be emphasizing on that, right? So when you see observational, normally what we do when a patient walks in, normally what we do, we observe. Okay, so it is generally we refer it as observational gait analysis. Observational gait analysis or movement analysis can be visual or can be recorded, and we can interpret the movements or the gait, right? And here when you see visual observational through naked eye, I just want you to just turn your eyes towards the diagram, that the video, a person is walking here. Just imagine a patient is walking to your clinic or to your center, and he may be walking with a similar gait. Okay, what do you observe here? What do you get out of this? Right? When I just raise this question, I have to observe here. I'm observing his ankle. I'm observing his knee. But what happens here is, yes, I did some analysis. He's got an heel strike. His knee is flexing and he's got an extension. There is an arm swing. Yes, I'm able to do it. But when it comes to some limitations here, we miss most of the gait deviations in normal naked eye analysis. It's more subjective, where you're just seeing there, or if you have an observational list, you can put a tick mark. Yes, heel strike is there. You have a knee extension, knee flexion, all these things you can put a tick mark and you can analyze. But most of the time we miss the gait deviation, and it's very difficult for you to differentiate between the primary abnormalities and compensatory responses. And also when I'm talking about measurable, you'll not be able to measure and say so much amount of dorsiflexion is present during the heel strike, or the quantity of motion during heel strike or initial contact in the knee is so much. You will not be able to quantify if you're doing it with a naked eye. So we have equipments which are there, which we use it in our day-to-day life, which I'll be talking about this. So normally what we do here is, I would like to have an interactive session, but it's more like as we are going live and interactions will cause a lot of disturbances, I'm just making it one way, okay? And you can raise your questions, you can put it forward, so we'll be able to answer. I think Sir is, Dr. Vijay Krishna is moderating the session, so he'll be taking up all these questions and we can discuss on this. So normally you already know this. As a physiotherapist, you can't say I don't know goniometer or digital goniometer or inclinometer, but how far we use this, okay, in our daily practice, we have to question ourselves. Okay, many times I said I'm taking practically myself when I was initial starting. Normally what we do, you tell a patient, if a patient comes with shoulder pain, I tell him to lift his arm, I observe, and I just have a notion that it is 90 degrees, it is 80 degrees, okay? And when I'm recording in the patient documentation, do we record the same values, what we see? Okay, we have to question ourselves. Yes, I used to do like simple like visualization, 90 degrees, 80 degrees, okay, abduction, internal rotation, external rotation, so on, okay? And you come to a hypothesis that it may be a PA shoulder or supraspinatus tendinitis, and you observe in this way and do it. But when it comes to clinical practice, we need to do it as an outcome measure. You have to measure it, okay? It can't be visualized, and you can't just tell by naked eye stating that this is the particular range. So it has to be measured. So normally we use, what we use in our clinics is, we use goniometer, already you know this, and we have inclinometer or bubble inclinometer, okay? And apart from this, we have some few apps which can be available in your Android or iPhone, like Goniometer Records and Gonio Pro. So these are some of the valid equipments which we use it. It's easy, cost effective, and it is less time consumption and sufficiently valid, and it is reliable, okay? But what we do here is, when I'm talking about the limitations here, when I'm doing it as an individual joint, yes, you can do it as an individual joint, a passive range. Yes, it can give you a value, and you can also do an active range and you can record it. But when you're doing a movement analysis, when you're doing a motion, it's functional motion. When you're telling him to sit, to stand, or climbing stairs, right? Or you're telling him to do a motion in bowling, or he's a bowler, so, or kicking a ball. When you're doing it, the goniometer becomes little tougher to examine or to analyze and relate with each related your proximal or distal joints. So it's very essential that you need to look forward further when it comes to your movement analysis. So you can still stick on, but even though we have electrogoniometers in place, we do it, but there are some limitations during your movement analysis. Okay, so these are some of the reliability and validity of goniometers which are available in the Android and iPhone. Okay, I'm not 100% recommending to use that, but when I'm talking about your easily available and measurable, you can still use it through phone, which you can always carry and record it with reference to patient name and the data. Okay, so coming to a part, I just want to take up few things away from the basics, like away from the theory part. Okay, so more of with the patient, so because that will be much more benefit to you. So it's when you do a movement analysis, it's very important that we have to analyze the range of motion or the quantity of motion. Okay, we do it by passive range of motion, we do it by active range of motion. Okay, so in spine, we do it with different, with accessory movements. Okay, and when I'm talking about it, it's very important how you position the patient during your assessment, right? Many times we just follow a comfortable position or standard what we have practiced in books or during your second year exercise therapy, how it's shown in the diagram. We just follow the same procedure, but we don't, many times I'm putting myself, I don't go much beyond the reasoning part or with reference to critical thinking. So it's important. I just want to give an example here. I just it's a passive range of motion on the left side of my screen. I think it's visible. The screen is visible to you. And when I see on the left side, I used a technique here in Kinovea software. This diagram was put and I just measured. This is similar to your goniometry measurement. You can, I'll just 1 second. You can see this part, right? You have the hip joint. I've just placed my stable arm to the trochanter, okay, greater GT, and the knee joint and lateral malleolus. So these are similar, the same method of goniometric measurements we have measured. So this is a passive range. I've taken it passively. So I've used the gravity to assist, and I'm having a passive range of motion of -5 degrees. That is extension. 5 degrees extension is normal, right? So 5 degrees of extension, okay? So when I see in your flexion of this person, okay, so the subject here, the flexion is again, you have got your flexion here. I measured here, it's around 149 degrees, right? And when I did in sitting, okay, same thing I just did in sitting of knee extension. So your knee extension was 8 degrees, okay? So what is happening here? What is the difference? So is passive joint range is around, in supine lying is 5 degrees, extension 5 degrees, flexion is 149. And when it comes to sitting position, when you're analyzing this movement in sitting, you are telling him to do sitting. For example, he's a footballer. He's coming with pain in the knee joint and in the posterior thigh. He's getting pain, on and off pain. After playing for longer duration, he gets pain in the posterior thigh. That was his complaint. And when he comes like this, I think most of you would answer this question. It is clear here, okay, what is the problem? So it is evident that you have to analyze with different positions, right? So what may be the reason here? Okay, in sitting, you have extension of 8 degrees, that is in flexion. He's not achieved extension. There is a lag. Okay, there is a quadriceps lag or extension lag of totally of 13 degrees difference, because when he wants to extend, he has to extend to 5 degrees. Extension is 5 degrees, normal is 5 degrees. So he has to get 13 degrees. He's lagging 13 degrees. So what may be the reason here? Okay, so it's very important you have to have key points for observation. So when you do it with your screening, or it may be a screening, or when you do an observation through goniometer, you get these values. And it's very important you have to correlate with key points. Okay, along with this, you need to have the key points. It's very important, as all of you know this, when you do a passive range of motion, it has to be accompanied with what we call it as the end field. Okay, when you do a passive range, you have to see the end field. What is the end field? Whether it's whether you have an end field which is firm or empty end field. Empty is painful, okay, where pain is limiting the motion, or it is in hard end field where the bone is coming in contact and there is a hard end field, or soft end field. So you have to mention. So based on this, you can always do a clinical reasoning. So when I assessed him, I felt it's in sitting. Okay, in normal, in extension, there was not much end feel here. Okay, I didn't feel much end feel, but still there was a firm end feel. I could still go further in this first part, left side diagram, 5 degrees. But when it's in sitting, I was not able to achieve full extension of the knee. It was a firm end feel. Okay. And also, it's very important that you have to analyze what is referred as P1, P2, R1 and R2. P1 is where the pain is restricting, the pain is restricting the movement. It's the minimal pain which is restricting the movement. P2 refers to the maximum pain, that is where is not able to, is not allowing, where the pain is more, where is limiting the movement. When I'm talking about R1, where there is a resistance felt during your motion, okay, minimal resistance. R2, where there is a maximum resistance, where you are not able to progress further. So you may have R1 here. In this case, there was an R1 which arose first. There was a restriction. Still further, there was R2 complete restriction, then followed by pain. There was a pain which was limiting. It didn't allow me to do further. It was a pain. And when I analyzed, I just want you to see the video and further. I'll just show you the video of this particular sitting posture as well as in lying down. So it's very important that you have to also, apart from this P1, P2, R1 and R2 end field, you have to also consider arthrokinematics. Arthrokinematics is nothing but the study of motion of the joint, articular surfaces. How does it move? Okay, in tibia, it is, you have the concave, convex, right? The femur is convex, tibia is concave. How does it move? During your extension, what happens if this is your tibial surface, your femoral surface of my left hand, when it's moving, it glides upwards. So to have an extension, it's very important that you have to have an anterior glide. It has to glide upward, anteriorly, right? So it's very important, and flexion again posteriorly. So the gliding arthrokinematics is also very important when you observe your movement, right? So it can be observed through your placements, okay, as a visual assessment, as well as you can do it by passively. You can assess the accessory movements by which you will be able to evaluate and quantify. And very important is, most of us miss is your proximal and distal joints. Most of time we miss. Okay, I've even tried for him. I've told him to do dorsiflexion, keeping the foot in dorsiflexion and extending. There was a difference. Keeping the foot, you can see the foot is in plantar flexed when he's doing in sitting, but actually when you see in supine lying, it's almost less than what is in sitting. Okay, and apart from this, when you're talking about the hip joint here, when I'm talking about the hip joint, the pelvis is more rotated posteriorly, right? It is rotated posteriorly. So when you see the video, you'll be able to understand where is the problem, and you'll be able to analyze and find out the reason for it. Okay, and very important, apart from this, muscle activity, because muscle also plays an important part that brings up the motion. When you're doing active movements, the muscle activity has to be observed, and also it can be measured through EMG. You can biofeedback and EMG. You'll be able to pick up the signals. The strength of the contraction can be picked up. Okay, so these are the key points. So I just want you to watch this video of the movement. It is an active movement. I did passive followed by an active. You can see the differences. Please observe ankle joint, hip joint, and the knee joint. What is happening there? Okay, what are the changes which is occurring? He is able to extend, but the quality of motion, you can see, is using his quadriceps. You can see this. Hope you are able to see my pointer. Okay. Yeah. You can see the quadriceps activity here, right, during his extension. Just 1 second. Okay. So during this activity, you can see quadriceps. Yes, quadriceps is good. It's working. Okay, but it's not able to overcome the force. Okay, so you can, if you want to have a measurable, you can still do with EMG, get the contraction, the strength of the contraction. Okay, and you'll be able to analyze this. Right. This is on supine lying. So in sitting, what is happening? Just observe the pelvis here. Okay, I just gave a feedback to sit straight. He's sitting straight here, I'm telling him to extend. So you can just watch again, just observe this. He's not able to sit straight. He's going backwards, right? So you can't just observe and you can't put it in the paper or document it. Okay, I can't just write his pelvis is rotating, his knee is not extending. So it has to be measured. So I'm emphasizing on this because you have to measure. You can use goniometric measurements, or the software which I'm introducing you today is a very efficient software. It's very simple, which you can use it for your day-to-day patient documentation and recordings. Okay, so what may be the problem here? What may be the problem? So this is the Kinovea software. Because of the time which I'm not able, I didn't do it on live. I'll be doing some sessions if there is time. I'll be taking up. But this is the picture which I got during your Kinovea analysis. So this is the range of 1 degree during your extension. This is active extension. Here in sitting, it's 16 degrees of extension, active. Previously, we saw the passive. This is active. So you can see there is a lot of difference here of range. So what may be the reason? Yes, I want you to answer by yourself, and you can put it in your box. What will be the cause for this, right? So, or what is your plan for further evaluation? So it's very important. We have to analyze your joint mobility. We have analyzed the joint mobility. It's fine, right? I did passive range of motion. Active, your passive range of motion of flexion was normal, 149, absolutely right. Extension, yes, I'm able to get 5 degrees of extension, which is optimal, which is required, which is optimal. So his joint mobility is fine, right? If capsule was tight, limiting the motion, then there'll be a passive motion also will be restricted. If joint was stiff, his passive range would have been restricted, but it is more of an active component which is restricting here. And when you observe here, when he's extending his knee, the pelvis is going for posterior tilt, and it's confirmed, or it may be with reference to your hamstrings, which is the culprit here, which is preventing him from extending his knee joint. He's a footballer. He kicks his ball with great force, right? So his quadriceps muscle is good. His force, I didn't check by dynamometer. I didn't do that now because it was yesterday. I didn't do with dynamometer. So his strength is good, right? And but what is happening here? The quadriceps function is not efficient because of the hamstring tightness, which is limiting the movement. So your plan will be on concentrating on your hip joint, knee joint, as well as your gastrocnemius and soleus, which you will be working, especially your gastrocnemius. And this is just an insight, okay? I'm not going into much in clinical part, just emphasize on evaluation. So it is important that you have to use these techniques either in goniometric measurements or by using this software, okay? So as I said, you have other methods, like all these methods like videography, your videographs, your sensors we use, okay? We use along with equipments like EMG, accelerometers, and electrogoniometers, gyroscopes, force platforms, pressure sensors. These are expensive, which you may not be able to use on all the patients or in all the cases, okay? So these are advanced techniques. I'm not going to touch with this. So this is what the Kinovea software is, okay? So do you want to take a question session so that before going into this, or do you want to have some discussion? Dr. Vijay, sir? Do you, because I'm not seeing the chat. I'm not following the chat.
Okay. So you can go ahead. We'll see if they want it, we'll get back to you.
Okay. So we have answers. Yes, we have some few answers which has been coming out. Yes, it's been hamstring. Most of you have answered as hamstring. Good. And yes, it's quadriceps, part of quadriceps, rector fingers already work. Hip flexor, that is why we have a lot of answers in the chat. Very good. So can I
continue, sir? We'll continue, sir.
Yes, sir. Okay. Thank you. So this is the software. I think most of you would have heard this and are using this software. So it's free. It's a free software which is available for download. You have to type Kinovea and you can get this downloaded in your computers. You can't use it in phone. It has to be done with computers. It's a 2D open video motion analyzing software, and it can be used for, it is used for kinematic parameter measurements, okay, mainly for the measurements. And it is low cost technology and has been used in sports science. And there has been validity, and the validity of this software has been tested, and it is shown its valid tool, right? So I'll just go into it. Okay, so what does this Kinovea features? Okay, so it's very important. What you need is, you need to have a capturing system. You need to have some method of videograph. Either it can be through your webcam or through phone, which can be transferred to your computers. So those facilities must be there, or it can be with cameras, HD cameras. So whatever is available, you'll be able to record. So it's very important that capturing system, or you must have the system in place. And second one is with reference to the software. What you do here is, you're taking the captured video or the photo and you're putting into the software for observation. Okay, and we can do a lot of annotation here, where you can mark it, you can draw, okay, you can put some landmarks, you can put some markers there, and which you'll be able to analyze, and through which you can have this measurements. Okay, so these are main 4 core systems where the Kinovea features. Okay, so the important, just a glimpse on preparation. Okay, first is your preparation of the body part or the patient is important. So we have some few marking systems which has to be done, especially in Gait. When you're using, you have to have the bony prominences which has to be marked. Okay, so these are like in foot, you have in first metatarsal, third metatarsal, and fifth metatarsal head. You have a marker. So markers will be placed something like this, what you see in the diagram. Okay, you can have a fluorescent marker. Preferably, I suggest you to have a fluorescent marker so that it is easily visible. Don't use the same color of the skin or with reference to your background. So you can use this marker which is easily visible and always matched with reference to the patient's skin. You can have different colors, green, orange, so which is more visible. And in ankle, you have in medial and lateral malleolus, calcaneal tuberosity, Achilles tendon, lower 1/3 of tibia anteriorly, and in knee, the lateral condyle of femur. See, I'm just putting it, instead of reading, it's just bony prominences which you take into consideration. So these are standard landmarks for identification through which you can examine. Okay, so hip, it's greater trochanter, ASIS, PSIS, iliac tubercle. Then in upper limbs, radial and ulnar styloid process, medial and ulnar medial and lateral condyle of humerus, and acromion process. Still want anteriorly, you can do it on the clavicle. Posteriorly, if you want to assess your scapula, you can still put a markers. So preferably you can draw a diagram or a marker using a pen, marker pen, the skin marker pen. You can draw with reference to your scapula or any part of the bone which you want to measure, the range of motion which you want to measure. Okay, and this what you see in the back is what is the postural grid, the postural analysis we use normally. So this will help you to analyze. For example, if I see this line, I hope the marker is visible. My marker is visible. So when you see here on the left side, okay, I'll just on the marker so that, yeah. Okay, if you visualize here and the same level, if I'm taking a distance from here, I usually measure a distance. Here also I take the same measurement. When I see the difference here, okay, this is what you have to do, a quantitative assessment. You have to have the measurement. You can't just say your left shoulder is elevated or right shoulder is depressed. So it has to be measured. Okay. So when you see here, you can see the box line. The left side lies in this line, almost in this line. Right side is lying in this line. So there is a lot of difference. So one box is measuring around 1 inch. So when you measure around 2 box, it's around 2 inch, there is a difference. So there is a drop in this right shoulder. Okay, this is what we do. So I can take this diagram to Kinovea software. I can measure, do the measurement. Okay, I can do measurement and I can record. And there is one very efficient way is you can easily download an Excel and you can use it for your research. Okay, it's a very efficient way where you'll be able to use it. And not only that, if you want to assess your ASIS, PSIS level, these things can be assessed here, and you'll be able to come with your proper one hypothesis, and with clinical reasoning, with further assessment, you'll be able to diagnose, do a functional diagnosis. Okay, so this is how about the markers and your postural grid, what you do on the patient. And very important, I just want to emphasize this, it's informed consent form has to be obtained whenever you assess a patient or whenever you take a videograph or a photograph, right? So you need to have the subject information form, you explain what you're going to do, and along with it, you have to have a consent form which is signed by the patient, okay? So this is a general view. I'm not going in depth of this because I'm not talking about complete on the analyzing system or technique. It takes a lot of time, and I prefer to do a practical where you're also with the computer and you're also analyzing with a photographic method or by videograph, and it will be much more benefit. Just an overview or giving an overview of your explanation. So here when you see this, the platform preparation is, studies have shown that, and Kinovea software, it is shown that at least you need to have 5 meters, the validity, it is shown like 5 meters distance from the camera to the subject. So minimum here, preferably we keep it below 3 meters, right? You keep it below 3 meters. So you can view it, usually you can have a 2D visual system where you can have it from the camera, from the lateral view. If you're taking a patient walking from left side to right side, you can have the camera here just placed on the lateral view and one in the frontal view. So you place 2 cameras and both can be recorded simultaneously and taken into the software where you'll be analyzed, where you're able to analyze, compare and analyze both these locations, that is sagittal as well as in frontal plane. So you must have 3 meters and total walking space, if it's gait analysis, it's around 10 meters distance totally, but 6 meter section is used for scoring. Okay, you take the best of this. Okay, so these are some of the things which you require for capture. Already you know this. You can even use a phone or you can use a camera where you will be able to analyze. Okay, next is observation, annotation, and measurement. I'll be talking with the example here. Okay, so that it will be very clear for you to understand. So this is an example here. Okay, this is an example of the software which I'm using. So here, I just want to analyze the weight here, where your biceps curls, when he's doing, he's able to flex so that you will be able to track this movement, how much amount of range is occurring in the joint. You'll be able to track this movement, right? So its starting point is around 25 degrees in flexion. Then you have flexion of 101 degrees. I paused it. And again, 140 degrees of flexion. Along with it, it's very important, as I mentioned, you have to observe the scapula, your humerus, that is the shoulder joint and the elbow joint, right? If there is more of instability or in the shoulder joint stability is not there, then you'll be using more of his axillary muscles. You can see a lot of motion with reference to shoulder, or in the elbow. You'll be using more of his axillary muscles where you'll be moving his elbow. You can see this once again. He's starting here. You can just track the elbow too. You can do this, right? And still further, the range. So this is tracking system which you can use. So you'll be able to obtain the angle with reference to time or the distance. You'll be able to obtain the range of motion or the angular measurement, which you can do it, the range which you see in the left side. And as well as not only that, you'll be able to calculate the velocity, the angular velocity, and also the speed. So these are the features which you are doing. If you are a sports physiotherapist or if you're working with sports people, sports persons, you can easily do this with analyzing this velocity as well as your angular movement as well as the speed. So it's a very efficient way of analysis. And also you can track the object. You can see this, you can track the object here. So you will get lines of tracking that's in the red markings. You'll be able to get this trackings. Okay. So there is questions. Can I just take a question now, or can we take later, sir? We have some question and answers. Can we do it later, or can we do a question and then go for applications?
Yes, sir. Later, sir. We'll do for later, sir.
Yes, sir. Yes, sir. Thank you, sir. So I'll just continue with this. Right. So when you see the application, I'll be talking in detail. I'll just show you a live demo how to do this. So we use this application of Kinovea in movement analysis, posture and gait analysis, calculation of spatio-temporal parameters, and in sports analysis, clinical analysis, and research. Okay. So it is a reliable tool. Okay. And which measures accurately at the distance up to 5 meters from object and at an angle range of 90 degree to 45 degrees. So preferably when you place a camera, place it at 90 degrees. It's preferably better so that you will get a clear picture. Okay. So coming to a gait, I'm just taking one example of gait analysis. We have seen some examples of movement. Still, I'll show some movement analysis techniques. So coming to the gait, already you know the phases of gait. Right, you have the stance phase and the swing phase, right, where stance phase is around 60% and swing phase takes about 40%. Okay, and when I'm talking about your example here, I'm just showing you one example on a patient, on a subject where you're able to analyze. You can, when you're observing here, you can see the markers, what is being placed with reference to what I mentioned there with the bony landmarks. So, and he's put on the camera, which is just directly facing here with the same 6 meters and with 3 meters difference. Okay, and all with these parameters. We did an evaluation for him. So this is what you observe here in the gait. So one of the advantages here, the speed also can be adjusted when you take into Kinovea software. Sometimes the speed may vary, right, with high speed, and when you're recording with low equipments, even these speeds can be altered. So when you analyze this, okay, normally when I'm analyzing the stance phase, I'm taking an example of stance phase here. So initially, the first point of contact in stance phase is your initial contact. I prefer to use RLA terminology, and also I suggest everyone to, where you're involved in clinical practice, to stick on to RLA terminology, because one reason is when I'm analyzing the initial contact of a person when you're referring. So the initial contact can be the heel, can be the forefoot. For example, if it's a person with foot drop or TA tightness, it can be forefoot or his toes. So when you write it in your document, it's important that you mention the initial contact. So the initial contact, if a person is having the heel as an initial contact, you need to mention, write it as the heel, right? So preferably, so when you use RLA terminology, you'll be able to do it. But when it comes to traditional terminologies, it refers as heel strike. So you have to write heel strike is present or not. So again, this gives you a lot of like explanations to be done. So preferably write it as initial contact. Next is your loading response, your mid stance, terminal stance, and pre-swing. So this is the stance phase of gait, what you're going to analyze. So when we did an analysis in the kinematic analysis of gait, so what we do here is kinematic, I referred you, it is the quantity of motion has to be measured. So you have to measure the range of motion in ankle joint and knee joint and shoulder and hip joint, right, and elbow, so that you can correlate with the normative values, and you can come with the clinical reasoning, come with the diagnosis, right? So when we did an initial contact for him, so this is the software which we used, through which you had knee joint is at 0 degrees. And when I'm talking about your ankle, it's mentioned 100 here. Okay, I just want to little add on to your description of motion here. So all of you know the magnitude, your measurements, how you're measuring, it's a positive or negative. When you're talking about your measurement in physics or measurement values, it is always a rotation component. When you're talking about ankle joint, it is rotation. When it's rotating in clockwise, you refer it as plus. When the movement is towards anti-clockwise, you refer it as minus. If it's a linear, if it's moving towards right side, you mention as plus. Left side, it's minus. So that this will be used in your research, or when you're calculating the force systems. This plays a very important role with reference to the positive or negative values. So when I'm talking about ankle, all of you know that 90 degree is 0, is a neutral. 90 degree is a neutral in your goniometric measurements. So when I'm talking about the range here, it comes to around 20 degrees, minus 20, that refers to it's in dorsiflexion. So 20 degrees of dorsiflexion, right? Is it clear? I think I made it clear. So when I'm talking about knee joint, it is at 0 degrees here. When I'm talking about extension, your extension here is 22 degrees. Okay, it's not minus, it's plus 22 degrees of your extension, right? And when I'm talking about your loading response, in loading response, it's ankle joint, it's around 16 degrees, 8 degrees of knee flexion, and shoulder, it's around 20 degrees. Similarly, when I do in mid stance, your terminal stance, and your pre-swing, okay, the pre-swing during your stance phase, you get this values. Okay, so what we have to do here is, it's always your values has to be correlated. What may be the reason, you have to come with a diagnosis. Okay, so his main complaint was his walking. When he's walking, his calf muscle is to pain, and he was not able to run for longer duration. So that was his complaint. So easily these values can be downloaded in Kinovea software. So this is the values which you see here. Okay, so I compare this with the normative values. I just want you to be little analytic here, little concentrating, with little critical thinking, okay, with some reasoning. So because I want you to analyze what is the problem with this patient. Is it normal, or is there any problem with this patient, right? So when I did an analysis, I've just put the normative values near, according to the studies, the normative values during your initial contact and your components, your phases of gait, it's been mentioned. This is what the patient name and his range. So initial range when he got in initial contact was around 10 degrees. Okay, and there was a value in this knee joint, it's 0. Again, he is fulfilled, it's 0. But ankle joint, it's around 10 degrees, minus 10 degrees, which he has got a difference. And here in the ankle, here loading response, it is 16 in the ankle joint, and normative value is around 5 degrees in loading response. There is a difference of around 11 degrees here. And same thing here, I'll just take up this difference so that it will be easy for you to understand. The ankle joint here, there is a difference here, but when it comes to your pre-swing, it is normal. And also the knee joint is normal here. So when you talk about this, what may be the reason? So when you analyze here, there is a decreased dorsiflexion for him. There is a decreased dorsiflexion. It is more of the plantar flexion is more of with plantar flexion rather than dorsiflexion. When it's doing a heel strike or when it's doing an initial contact, there is a difference of your initial contact value. There is a difference. So when you conclude, when you just relate here that the reason may be because of TA tightness, right, where your calf gastrocnemius is tight, where he is having problem with the gastrocnemius tightness, which is affecting his knee joint, here, so that when you're seeing in the mid stance also, he's always keeping his knee in flexion. His knee is in flexion. Whereas when you see in stance phase, the ankle joint is fine, it's free, but is able to have this normative values in the knee joint and the terminal in the pre-swing. But when you see in the mid stance and in the heel strike, in the loading response, the range of motion in the ankle is altering the range of motion in his knee joint, right? In this knee joint, it's altering. So you can see this here, the normative value is 15, but here it is going less. So the reason may be because the hamstring, the calf muscle is tight, and mainly your gastrocnemius, so which is not leaving you further to go into dorsiflexion. So when it's putting the weight, it has to compensate with knee flexion so that to relax the gastrocnemius. So he's not able to extend his knee during your loading response as well as in the mid stance. So this is how you have to bring up, or you have to come up with a clinical reasoning. I've just given you an insight on how to analyze the movement and the gait and how to interpret. I've not taken condition wise. If we would have taken condition wise, we would have discussed. And also I'll keep this open for discussions further so that you'll be able to evaluate. Okay. So if we still have time, okay, I'll just go with Kinovea software. I'll just demonstrate how to do it so that it'll be easy for you to understand. So can we go with a demonstration of Kinovea software? Is it okay?
Dr. Sai.
Yes, sir.
Yes, sir.
Yeah, time is there.
Yeah, that's what, sir.
No, we have some more time, sir. Yeah, we can go with the questions.
Okay.
Right.
Can we go now? Can we go?
Yeah, we can take up the questions. If they require, I can just have a small demo of Kinovea software and I can just show them so that we can pick up the questions or.
Right.
Okay. So I'll just give away, I'll just complete the session here with the key takeaways which you have to analyze, because movement analysis can be carried out with various methods. So you need to select what method are you using. Okay. And I strongly suggest that it has to be a quantitative and qualitative method where you put it into your document. So when you analyze, so preferably using a cost-effective methods, simple methods, which is easier and highly valid is preferably better. So in this way, you can go into the goniometric measurements, your inclinometer, right? And as well as the software, like Kinovea software can be used for analysis. And it's very important to make use of these methods to quantify movements and apply critical thinking, use the clinical reasoning, and which will help us to bring with proper functional diagnosis and effective treatment. Okay. So as to conclude, it is you must quantify, it must be objective, and you need to have a documentation, so which can be used in further research. So this, by which I conclude this, and that's what we'll go into. These are my references, and we can go into the questions now.
Thank you, Dr. J. Samuel, sir. Are you getting me?
Yes, sir.
Thank you, sir. Thank you for the wonderful presentation. Okay. I think we have again refreshed this biomechanics, some of the important points and the things. Right. I have some questions regarding this thing. Will this software give any automated output, or we have to analyze? Sir, you're getting me.
So can you come again, please?
No, will this software, like Kinovea software, will give you automated output, automatic answer, or you have to interpret?
No, sir. It gives you value. You have to just do a drawing, or you have to mark it, like what you've seen the markers in my previous slides. When you see that, you have to do this. It is not automatic. It will not pick up with sensors. It's not like picking up with sensors. It's not a motion analyzer. You have this marker. You need to mark this. So when you mark it, the values will be automatically measured. You need not measure it, or you need not give it. It's automatically measured. And also this can be downloaded through an Excel format.
Fine, sir. How far the validity of the Kinovea software, sir? Any research is there?
Yes, sir. We have research papers on Kinovea, and recently recent article which I mentioned by in 2019, Kinovea software is a reliable tool. They have done with other mechanical methods, okay, by engineering mechanical tools, which they have analyzed and which they have compared, and they have stated that it is a reliable tool, and also the measurement of distance and at which distance it has to be measured is also stated. So it's a reliable tool, and a lot of studies have come up with that.
Okay, fine. Dear participants, you can you can have a direct questions to the speaker. So anybody have a questions? Please kindly come down. Anybody is there? Dr.Sai Mahendra?
So I think we can take the questions from the chat box.
Okay. Some of Dr. Vijay sir.
Yes, sir. I'm just seeing the chat box. So
first question is yes, they asked about the reliability also.
Yes, sir. That's been answered.
And I think we answered it. One is like the difference between goniometer and inclinometer.
Yeah. So goniometer and inclinometer. Goniometer is simple like a measurement where you have 360 degrees or 180 degrees goniometer, where you have a stable arm. I'll just show you the diagram so that it will be easy for you to understand. Right. So this is what you see in the right corner, down corner, you can see the goniometer, right? So this is not based on your gravity. So you have to fix a stable arm. Your stable arm is fixed, and you have a movable arm through which you can measure the angle. But when you come to the what you see on my right side, where you have a blue color mark R, which is a bubble inclinometer, which you have a fluid. So this is gravity. This is based on the gravity. So whenever you tilt, it again moves. So you have initial markings which can be set, and when a body moves, you'll be able to measure it with reference to your gravity. Right? So it is just a measurement as a tool. Okay. So I'll just even if you are able to see the softwares in your phones. Okay, you can see the softwares in the phone. So for example, you have an iPhone where you have, I think it's not clear, right? So when you see this range, okay, so you can, it's similar to this. Okay, what you see is similar to this, where you're able to rotate. It's similar to this, where your degrees can be measured according to how you turn, right? The bubble inclinometer also is the same pattern, which moves, okay, and which you're able to get it. Okay, that is what the answer for the question here. Yeah.
The third question, right, like I think that's the answer you have given. The fluorescent marker placed physically in the patient body. Yes, it will be physically placed, right?
Yeah, it's physically placed on the body. It's a sticker.
Yeah, that's it.
You place it on the bony landmarks, and you can remove later after your treatment, after your assessment. So it's a fluorescent marker. It's physically placed on the body.
So this
and also one of the important to answer this question, if you're not able to do it, for example, you have done a video recording of a motion. It may be a sports. A person is doing a high jump and you have recorded video. You're not done any marking for him, but still the software, in the software, you can do the marking, right? You can also identify the bony landmarks and you can still mark it, but it will be an imaginary points which you are doing it. So preferably it's always better to have a fluorescent marker.
So that is also again a questionable about that marking and this thing. Reliability is little bit difference is there, right?
Yeah, if you are not marking, then again it is on imagination. You have to mark it on the video through the Kinovea software. There is an option
marking. Okay.
There is option.
And other thing like whether the software, I think it won't capture the muscle activity, right?
No. It will not. It's a purely a kinematic analysis. It's not a kinetic analysis. It's purely a
You need,
kinematic analysis. Mainly your range of motion. You can have the speed measured, the velocity which can be measured, the distance can be measured, range of motion, angular velocity, linear measurement, angular measurements can be done, but not the muscle activity. So muscle activity, you need to go into a EMG machines or through sensors, through sophisticated motion analyzer.
other questions, like I think I'm filtering it and getting back to you, sir. Like I think any other software like Kinovea is there, which is reliable and valid. And this is also reliable one. Comparatively, any other software they're asking, I think.
So frankly speaking, I have not exposed much because I'm what we have used since years. We are happy with Kinovea, and it's a free software, so it's available for everyone. Those are in practice, can easily download and can use it. Some softwares are there which are paid versions are there. Even Kinovea versions are paid, some versions are paid. But preferably, this is much more easier to measure and easy to predict. So frankly, I've not analyzed into other softwares much.
And I think so others will be different questions like assessment, goniometer, and inclinometer steps.
Yes, sir.
Any other questions, participant? I think this will be the better one. I think so.
Yeah, iPhone, that validity, what is given as goniometer. Somebody has asked, can you name the goniometer repeater? This is what depends on the studies. They've done two studies keeping the iPhone about two softwares. So based on that, you have clinometer. That's also a valid tool. Apart from this, you have goniometer records, and also you have G Pro, right? Goniometer Pro, G Pro. It refers as G Pro. That is in iPhone, which you can use it. Okay. Apart from this, a lot of softwares, applications in your phone, which you can download and use it. It is user friendly. Whichever you feel it's better, you can still do it. Okay, and also look into some studies which has got validity they've checked, and preferably use those softwares so that which will give you a proper value or correct value. Yes, sir. They're asking for assessment. Yes, sir. I just want you to take up this, sir. If there is questions, any more questions which I need to answer. Dr. Vijay, sir.
Sir,
Yes, sir.
I think I muted it. This software, where it's from, it has been like any company or
yes, sir.
anybody.
So this is developed. So this software is developed by the professionals, mainly the sports professionals, and mainly by the clinical persons who are in research field, and they kept it as a non-profit, and mainly to use it among the researchers, athletes, and coaches and programmers from all over the world. Okay, so it's a non-profit, and it is freely available. So it is done by a set of people, which is available for free to download.
Okay. Any other questions? I think.
So I think we're done, and I'm sure the questions are coming in, but we're shortly, running out of time. So can we wrap up the session, sir?
Yes, I think. What, sir? Vijay, sir?
Yes, sir.
It's been a wonderful presentation. Again, it's a brainstorming presentation by you, sir. And I think it was a wonderful day. And I think most of the participants, they got some idea about that Gait cycle. How I have to do it, whether to do it, whether to not do it. Some people are in a confusion like we can do it in goniometer. This is overall. It's a gait analysis. It will be helpful if you have doubt. If you want to conclude research-wise to get a correct picture, because nowadays validity is important. I keep telling my students validity is important. Without validity, will be always a question mark is there. So that's what I'm telling. So it was a wonderful session, sir. So thank you for your valuable time and presentation. This thing. And again, thank you for KSPF to give opportunity, Dr. Ayappan sir, Vinod Babu sir, and Dr. Sai Manohar sir, Sai Mahendra sir to give me opportunity. Thank you very much, and keep creating like this platform to coming sessions and all these things, sir. Make it up everything like in this particular COVID season. Everybody has to be in a great knowledgeable particular student. So thank you, sir. Kudos to KSPF.
Yes, sir.
Thank you.
So
Thank you
thank
so
you,
much,
sir.
sir. Thank you.
Especially at this outset, I'm just big thanks to all the participants who have participated. Okay, and my acknowledgements to Dr. Ayappan, the president, the KSPF, Dr. Sai Mahendra, sir, secretary of KSPF, and Dr. Vinod Babu, and also the advisory board members, all the board members, and the office bearers. I'm really thankful to them. And apart from this main together, Dr. Vijay Krishnan, he was coordinating this event well. So I just my heartfelt thanks to you, sir. Apart from this, I'm grateful to Dr. Kavita Raja, who has been an insight, who has been encouraging me, giving me all the inputs, and thankful to Madam also regarding all this data analysis as well as harmometer analysis. And thank you, sir. It's a wonderful platform. You have been keeping open for all the professionals and students.
Coming years, I think you should have a good. Coming years, you should have a good participation. I think you're getting me, sir. Coming year, you should participate more on these things, sir. I best wishes for you, sir.
Thank you, sir. Thank you.
Thank you so much, for beautifully moderating the session here, and thank you, Vijay Samuel sir. It was really a fantastic webinar which we have come across biomechanics, and I'm sure we will have many more such webinars from you in the future. Just a reminder that tomorrow we have another session of webinar. That is the topic would be common misconceptions and misdiagnosis in physiotherapy and how to overcome them. We have a wonderful speaker here called Karthik Shah, who's founder, director, trainer into Canada Education Services. The session is going to be coordinated and moderated by Dr. Radhika Anand, who's director and chief physiotherapist, Rapid Religa Physio Center, consultant and executive committee member. So we're going to have a fantastic session tomorrow. I would request all the participants to join us same time at 6 p.m. And I really thank both of you today. I'm sure that participants who attended this would take home a very good information and try to utilize them in their day-to-day practice. Thank you very much, sir.
Thank you.
Good night.
Thank you. Good night.
Thank you, sir.
Thank you.
Good night.
Thank you, sir.